Welcome to this explainer. Today, we're basically simulating ward rounds. We're going to systematically master those high-yield metabolic concepts that literally save patients' lives. I'm so thrilled you're here with us. We're going to dive right into 16 targeted clinical scenarios, complete with multiple-choice questions, to break down the exact math, the precise formulas, and the physiological logic you really need to know. Let's get into it. Here's our roadmap for today. We'll start with the foundations of body fluids, move into sodium and osmolality, tackle managing calcium and potassium, and finally wrap up with acid-base disturbances. All right, starting right off with Section 1, Foundations of Body Fluids. Okay, before we can even think about fixing fluid deficits, we have to know what we're actually made of, right? So question 9 asks about the percentage of water in total body weight. The crucial point here is that water makes up roughly 50 to 60% of an average adult's weight, making C the correct answer. To put a finer point on it, an average young adult male is about 60% water, while a young female is closer to 50%. And honestly, that variance is simply down to natural differences in adipose tissue and muscle mass. Let's put that into practice. Question 16 looks at daily maintenance fluids for a 60-kilogram woman. We use the classic 150-20 rule here. It's kind of like building a layered cake. For the first 10 kilos of body weight, you multiply by 100 milliliters, giving us 1,000. Next 10 kilos, multiply by 50, adding another 500. And for the remaining 40 kilos, you multiply by 20, adding 800. Add the whole shebang together and you get exactly 2,300 milliliters of daily maintenance fluid. Super straightforward once you know the rule. Moving to question 7. When we inevitably have to resuscitate someone, we usually reach for normal saline. But what's actually in that bag? Well, the answer is D. It packs 154 milliequivalents of sodium per liter, balanced perfectly by 154 of chloride. Now, keep in mind, because our normal plasma sodium is usually around 135 to 145, 0.9% normal saline is actually mildly hypertonic compared to our blood. Now, sometimes we need more than just crystalloids, but you've got to be careful. As question 8 points out, if you rapidly push 5% or 25% albumin, it draws a massive amount of fluid right into the intravascular space. That makes it a huge risk for triggering pulmonary edema due to that spiked intravascular oncotic pressure. On the flip side, hydroxyethyl starch solutions have a totally different danger profile. They're the ones you typically associate with coagulopathies and severe bleeding issues, not albumin. Moving right along to Section 2, Sodium and Osmolality. Look at question 2, dealing with postoperative hyponatremia. What's absolutely fascinating here and trips a lot of people up is that antidiuretic hormone, or ADH, actually increases transiently after surgery. It doesn't decrease. Hyponatremia usually comes from excess free water or sodium depletion, so things like drinking too much water or taking medications like antipsychotics that make you retain water can easily tank your sodium. But option C is false, making it our correct answer because the physical stress of surgery actually triggers your body to secrete more ADH, not less. So what if a patient is severely hypernatremic? Question 12 treats this math like a clinical puzzle to find exactly how much free water is missing. You take their current sodium, subtract the ideal 140, divide that by 140, and multiply by their total body water. Let's look at a 70-kilogram guy. His total body water is about half his weight, right? So 35 liters. If we plug in a dangerously high sodium of 154, the math gives us a free water deficit of exactly 3.5 liters. Boom, that is exactly what you need to replace. Question 10 is a great reminder that osmolality is not just about sodium. The calculated serum osmolality formula includes sodium, BUN, and glucose. Because we divide glucose by 18 in that standard calculation, a 180 milligram per deciliter spike in glucose directly drives up the serum osmolality by 10 milliosmoles per liter. That's why C is correct. It's such a high-yield clinical pearl because it perfectly explains why severe diabetics end up so profoundly dehydrated. It literally pulls the water right out of their cells. Then we have question 6 regarding 7.5% hypertonic saline. This brilliantly illustrates how medicine evolves. Contrary to older, outdated assumptions, hypertonic saline is actually highly beneficial for patients with closed head injuries. So the false statement here is that it should be avoided. In reality, that super salty 7.5% solution acts like a sponge, pulling fluid out of the swollen brain tissue. That decreases intracranial pressure, which directly increases cerebral perfusion right when the patient needs it most. It's a real game changer. All right, diving into Section 3, Managing Calcium and Potassium. Let's look at question 3. The Socratic method demands we ask, what is the absolute first ECG change you'll see in hyperkalemia, before a deadly sine wave forms? As potassium climbs, the cardiac membrane gets incredibly unstable. The very first warning sign on that monitor is the peaked T wave. If you don't catch it and treat it, the progression is ruthless. You get flattened P waves, a prolonged PR block, a widening QRS, and ultimately, a fatal sine wave and VFib. Which brings us to question 14 on treatments. The absolutely crucial point here is that IV calcium, option D, doesn't actually lower the serum potassium at all. It simply acts as a shield, stabilizing the cardiac membrane to prevent toxicity. Things like bicarbonate and the glucose-insulin combo, they actively shove potassium back into the cells, which temporarily drops the serum levels. Kayexalate physically removes it from the gut. But calcium, it just buys you time. It protects the heart while you work on actually fixing the potassium level. Check out question 15. This is a classic scenario, an alcoholic patient with low potassium and low magnesium. Listen, you can pump a patient full of potassium all day long, but if they are magnesium depleted, that potassium won't safely rise. You have to aggressively correct the magnesium first. Hypomagnesemia totally wrecks intracellular potassium homeostasis, causing this refractory hypokalemia. So the correct next step isn't more potassium boluses, it's giving intravenous magnesium sulfate. Hit the nail on the head with B. Moving to question 4, about severe hypocalcemia. You've got to separate the underlying causes like severe pancreatitis or hypoparathyroidism from the deadly manifestations. When you're standing at the bedside, the physical signs are what you're actually looking for. Severe muscle cramping, a prolonged QT interval on the ECG, and if it gets bad enough, decreased cardiac contractility that leads straight into heart failure. Question 13 shows exactly why you must always correct for hypoalbuminemia. If you just look at a measured total calcium of 6.8, that looks terrifyingly low, right? But this patient's albumin is severely depleted at 1.2. We have to adjust for that. We multiply 0.8 by the drop in albumin, giving us a correction factor of 2.24. Add that back to the 6.8, and suddenly you realize that terrifyingly low calcium is actually a perfectly safe 9.0. Crisis averted, just by doing the math. And finally, section 4, acid-base disturbances. Look at question 5. We have a profoundly acidotic patient with a pH of 7.1. What's the next test? Well, because you literally cannot calculate an anion gap without it, getting the serum bicarb is the absolute most critical next step. The anion gap formula is sodium minus the sum of chloride and bicarb. Without that bicarb level, you are flying blind. You have no idea if you're dealing with an elevated gap or a normal gap acidosis, and your entire diagnostic process just stalls out. So A is the correct answer. Question 1 breaks down the causes. Notice how severe diarrhea directly causes a normal anion gap acidosis. That's because the massive bicarb loss from the gut is symmetrically replaced by chloride. It's a one-for-one swap. Meanwhile, things like diabetic ketoacidosis, renal failure, and starvation dump brand new, unmeasured acids into the blood, which elevates the gap. But GI losses like diarrhea or fistulas just trade a negative bicarb ion for a negative chloride ion, so the overall gap stays exactly the same. Okay, let's look at this final calculation in question 11. As the blood becomes rapidly alkalotic, potassium shifts right into the cells, dropping serum levels dangerously low. The golden rule here is that serum potassium drops roughly 0.3 milliequivalents for every 0.1 increase in pH. So let's say a patient shifts from a normal 7.4 up to a 7.8. That's a 0.4 change. 4 times 0.3 equals a 1.2 drop in potassium. That means a baseline potassium of 3.4 plummets down to a critical 2.2. To wrap up this explainer, I want to leave you with this thought. Mastering this isn't just some academic exercise. Every single one of these multiple choice scenarios represents a living, breathing patient in a hospital bed whose fluids, electrolytes, or acid-base status is dangerously out of whack. You now have the formulas and the clinical pearls to stabilize them. But it begs the question, the next time a patient's labs come back critically deranged, will you just treat the number on the page, or will you treat the intricate, shifting metabolic puzzle inside the patient?